Good morning, everyone, to the second day of the SMRA. And I'd like to welcome you to the first plenary session today, Envisioning the Future of Cardiac MRI. And we were instructed we have to be quick and leave the room on time. So, my name is René Bottner. I'm from the Pontificia Universidad Católica de Chile, and my co-moderator is James Carr from Northwestern University. And we're going to start with the first presentation, Harnessing the Potential of Low-Field Cardiac MRI, Key Technical Developments Needed, which is given by Matthias Stuber, who I hope everyone knows.
Thank you very much, René, for the kind introduction. And I would like to thank the organizers for inviting me, and also you for coming out this early, so I don't have to stand here by myself like a little sad puppy dog. So thank you for that. All right, so what? You know, is cardiac MR even important? And if you look at this slide that was given to me by Lon Simonetti, then clearly there is increasing evidence that cardiac MR is becoming more and more important with an increasing number of guidelines, class 1 and class 2 indications. However, only about 50% of the world's population has access to MRI. And if you're thinking in this context about cardiac MR, which is very difficult to perform and where user interaction is actually quite complicated, then it's certainly safe to say that the vast minority of people only have access to cardiovascular MRI. Okay. So recently, low-field systems have been marketed by some of the vendors. They are commercially available. However, at 0.55 Tesla, of course, we have a reduced signal-to-noise ratio, which as a result requires prolonged scanning times. Then, on the other hand, there is also the challenge that fat and water are much, much closer together. So that makes also water a fat selection or fat suppression much more challenging as a result. However, the new magnet designs that are currently available with zero boil-off, large bores, no quench pipe, no helium refills, and lightweight magnets makes this much, much easier to install, and it makes it also more cost-effective because also they are more economical in their production, installation, and maintenance. At the same time, we have ever-increasing computing power. We have the advent of artificial intelligence algorithms and cloud computing. So there is something that ought to be harnessed in that context. So here on this slide, you see the challenges on the one hand and the potential on the other hand. You see there are a lot of potential advantages. Last but not the least, also reduced magnetohydrodynamic effect that pollutes the EKG much less at low field. At higher field, then the bore size is increased, which allows to do exercise or to scan obese patients. And of course, the other advantages that have already been mentioned. And talking about SNR, and this slide was given to me by our chairman, René Bottner, they used a dependent deep image prior. And you can see on the left-hand side, sense, grasp, and then two different flavors of this deep image prior, and you can clearly see how tremendously the image quality is improved. And when I was looking at that slide, René, I was thinking, how is this going to perform at 3 Tesla, you know, if you use these algorithms at the higher magnetic field strength. Now, on the right-hand side, you can also see the cines at different anatomical levels, very clever technique. And I personally would be hard-pressed identifying that these images originate from a low-field system. These images were given to me by Adrian Campbell, where they implemented at the NIH comprehensive exams to answer all kinds of clinical questions. You can see cine flow, perfusion, even angiography, late enhancement, and parametric mapping. However, I also have to disclose that some of these images that are shown have been acquired on ramped down 1.5 Tesla systems with a higher gradient performance. So not all of the images I'm showing were acquired using the same gradient performance. Patricia Panettini, the SCMR, gave this presentation here and generously gave me the slide where they answered a bunch of different clinical questions already at low field. And they concluded that they have a high confidence for diagnosis and management in the vast majority of the patients they're investigating. If you're interested, there is also a paper published about that. Lon Simonetti gave me this slide here where 0.55 Tesla is compared to 3T, and you can very clearly see that the image quality at low field really stacks up. However, if you look at the late gadolinium enhanced image, clearly the scar doesn't look as sharp, as well delineated at 0.55 Tesla as at 3T. And even perfusion works well, lower magnetic field strength. Of course, at 0.55 T, when compared to 1.5 T, we also expect a lower artifact pressure in the presence of devices or artificial valves or external wires. And here on the left-hand side, you can see a cross-section of the ascending aorta at 1.5 T and at 0.55 Tesla. And very clearly, the artifacts are much reduced as a result of the lower field strength. And on the right-hand side, you can see the equivalent of the CINI, the BSSFP CINI acquisition, where again, the artifact is quite considerably reduced. Then at the NIH, of course, they have done traditionally a lot of interventional imaging. So that was like a slam dunk to try this also at lower field strength. And they did their due diligence and looked at temperature increase in devices. And on the right-hand side, you can see guide wire heating experiment at low field at 1.5 Tesla, where very clearly at low field, the heating is much reduced and compared to the higher field strength. And here I can show you an example, I hope it's playing, yep, of an IVC stent deployment in an animal model, where you can slowly see the stent advancing here at this level. I don't know whether you can see my mouse, no, but you figure it out yourself. Where the stent is advancing, and the frame rate seems to be sufficient in order to image this, and this was published just very recently in JCMR. Then Nicole Seiberlich was giving me this slide here, where they used a very elegant rosette trajectory to do fingerprinting, and them as well, they used deep imaging prior. And you can see how very nicely the septum, for instance, in these images is delineated when compared to the conventional approach. And clearly it outperformed low rank, so exquisite image quality as a result of a combination of his rosette trajectory on the one hand and the deep imaging prior on the other hand. Now, I also can tell you, and this is an image acquired at our institution, when you put people in the magnet to do exercise, now you can put all sizes, all heights into the magnet because the knees just simply do not touch the bore anymore. That means that you really can perform in-bore exercise using this 0.55 T magnet. You don't have to put the patient out, exercise, and then put the patient back in. So this works very well. And here you can see a movie of a poor volunteer who had to do this just for the movie's sake. You can see him pedaling here, and he is about 1.80 meters. I don't know how much that is in feet, but clearly you can see that he doesn't touch the bore with his knees. And I'm not sure. This is not playing, at least not for me, for you neither. Okay, you have to take my word for it, what you would see there. This is a movie at rest and during stress with a temporal resolution of about 100 milliseconds. And at stress, you can clearly see how the up and down motion coming from pedaling is overlaid to these real-time images where you see the heart contracting and relaxing. However, again, the frame rate here is modest with 100 milliseconds duration because of the modest gradient performance. So with advanced gradient systems, I think this will be becoming even better. Interestingly, if you look at an EKG at the same time, at the top you see an EKG at rest, and at the bottom during cycling exercise, and there's very little artifact overlaid on that image, and very clearly at the region of the T wave also, which is usually augmented because of the magnetohydrodynamic effect, you see no artifact at all, and this can be attributed to the lower field strength. However, I have to say on our system anyway, there is currently no EKG devices implemented directly. These have to be external units, and we have one of those here but this works fine as well. You just plug it in and it works quite well. Now, of course, there is also the potential for increased accessibility on many different levels on the one hand. However, I think we also ought to improve the ease of use in order to support a more global dissemination. So on the one hand, you should have easy to use and affordable technology, while on the other hand, no specialist operators should be needed in order to bridge this education gap. And one step in that direction, this slide was also provided to me by René Bodnar, is this very elegant INAV technique where a small real-time image is acquired to guide then that acts as a navigator for respiratory motion binning, including motion fields, gets you to a very simple and fast exam. And here are some of the images that were given to me and René. I think these coronaries almost look better than the ones we acquired some 25 years ago. So it's very interesting to see the quality here. However, ideally what we would want, and on the right-hand side here you can see that we always use EKG electrodes, of course, for cardiac imaging, sometimes navigators and breath holds. Ideally, we would get rid of that. What we would want to do is just simply position one box on the heart, one glorious mouse click, and out comes a volume that can then retrospectively interrogate it for all kinds of information. Of course, that's something we would want to have, but we are not quite there yet. Nevertheless, this free-running framework was implemented on a low-field system together with a very nice collaboration with Lance Simonetti. Xavier Sieber implemented this. It's a one-click solution, takes about 8 minutes to acquire, doesn't need contrast agent, and on the top you can see the 2D cine images acquired at low field, and at the bottom these free-running images with total self-navigation, no EKG or no breath hold needed. And the measurement concordance with the reference standard, both for volume mass and function ejection fraction, is actually quite favorable. Similarly, these images were given to me by Ifina Akporea. He also implemented flow, 5D flow imaging at low magnetic field strength, acquired during free breathing. However, if you look at the scanning time here, very clearly this is quite long. And the simple reason for that is, again, the gradient system, the TR is relatively long. And of course, this increases the scanning time considerably. But I think with the newer gradient system systems that will come out, the scan time will easily be reduced to half of it. And also here, the measurement concordance with 1.5 Tesla reference standard was very good. This slide was given to me by Stan Rapacci. He uses a B-star approach. This was originally proposed by Oliver Beery, where you basically start in the center of K-space, you go out on a radial spoke, and you can come back in. So this makes the duty cycle actually quite high on the one hand. On the other hand, affords the advantage that you can reconstruct two images, one UTE image, one image with a longer echo time, and this lends itself very well to do water and fat separation, as you can see here at the bottom. It's not perfect yet, so he's getting there, but nevertheless, this is one possible route towards fat separation on these low field images, as I mentioned in the beginning, which might be one of the challenges because the water and the fat peak are much closer together. So to conclude, what are the key developments needed? First of all, hardware and instrumentation. I mentioned it a couple of times. I think we need more performant gradients in order to do cardiovascular MR. And even though I don't care so much because we work on this free-running framework, I think EKG hardware still should be integrated in these devices. And then it will be very interesting to see what comes out in terms of interventional devices for performing interventional cardiovascular MR on these lower magnetic field strengths, because again, first of all, the heating is reduced, and secondly, the artifact pressure is much lower. So therefore, this might be a very interesting application. And I think this is also interesting to investigate different case-based trajectories. You have seen this, this rosette trajectory from Nicole Seiberlich, or the B-star trajectory, which is also leading to very good images at low field. We currently are also investigating cones, a 3D version of it, and of course, effective approaches to fat suppression are another very important endeavor. And if there is a young PhD student in the room who would like to wrap her or his mind around this problem, I think this would be exquisite to focus on this fat saturation problem at lower magnetic field strength. Then, of course, workflow, usability and training. Really, we have to work on techniques that bridge the education gap. And I think open ecosystems are going to be critically important so that these techniques can be freely disseminated worldwide. And I think also their collaborations with different international centers are going to be critically important. And I think target applications that are also particularly interesting are exercise CMR and interventional CMR. And with that, I'm to the second finished with my talk. Thank you very much.
Okay, thank you, Matthias. Right on schedule, not slipping up. So we're going to take questions in a group discussion at the end of the session. So stick around. So our next talk is Jeremy Collins from Mayo Clinic is going to talk about bridging modalities, unlocking the combined power of cardiac MRI and CT.
All right. There we go. Okay, so uh-oh. You'll see that. We'll go with that. Mac user. So that's the first problem. Movies wouldn't play. So that's great to be here. I want to thank Judith again for the excellent organization, all the work she's done for the meeting. And so yeah, I'll be talking about cardiac MR and cardiac CT and how I can use them together, or maybe one versus the other in certain situations. Outline. So I'll briefly touch on the unique strengths of both, briefly touch on photon counting CT. This is a great modality, but unfortunately, when you order a CT at our institution, it's rare your patient would end up on one of these scanners. We just don't have that many. Then I'll go through some cases as examples here. You know, so why cardiovascular MR? Well, I think, as we all know, it's the standard reference for biventricular size and function. It offers a comprehensive study. You know, you can do the entire exam with function, flow, tissue characterization, late GAD, stress perfusion, rest perfusion, whatever you'd like to do. The technique is very mature. It's mature across field strengths, becoming even an option at lower fields, as Dr. Stuber just talked about. You can combine it with MRA to allow you to look both comprehensively at cardiac and vascular function. There's some challenges still. I think some centers have become very good with devices. You still have to mitigate those the device-related artifacts locally, even if you can get the patient in your scanner. And even under the best scenarios, your total exam time is going to be a bit long compared to CT. So what about cardiovascular CT? Well, this is a very mature modality. Now that there's 64 slice and greater slice scanners everywhere with ECG gating capabilities and expertise on how to acquire this data, you can get robust images of the heart pretty much independent of patient factors. There's still some difficulties optimizing those image quality issues in patients who have arrhythmias, perhaps have stents, you know, leads. They're larger patients. They have difficult IV access. There can be challenges in that scenario as well. And just like for MR, you can combine it with angiographic acquisitions for a comprehensive assessment of the heart and the vasculature. Arrhythmias, I mentioned we can solve them, but it does require, you know, prospectively thinking about how you're going to acquire the data and then working with your technologist to optimize the acquisition. And this can sometimes mean going to the scanner yourself, and it can take a lot of time. With older technology, stents, calcifications are an issue. Beam hardening artifact can be problematic. We can overestimate the degree of stenosis in the coronaries and have a hard time distinguishing what we're really looking at in certain lesions. And I'll say with current state, there's still limited tissue characterization capabilities, but if you do optimize the acquisition, you do have some other things at your disposal. And so I'll briefly touch on a few strengths of photon counting CT building on what was shared yesterday. The benefits, again, I'll say maybe potential benefits if you don't have one of these systems, or already hear benefits if you have access to one, are myriad. And the ones that we think are the best at Mayo would be the spatial resolution improvements that one has, and the ability to really see specific energies of the photons. So you're able to look inside stents, you're able to see branches of the coronaries that were previously unevaluable. You're even able to see stenoses in those branches, which are outside of the CAD-RADS criteria if you're reporting for coronary stenoses. And this is an example from Shuai Leng at Mayo, showing a EID CT image there on the left. Significant, beam hardening. You can't really make out the stent interstices compared to the right, where you can see this precisely. And this is another example of how the difference in the amount of total calcification that's there, right? So if you're looking to quantify plaque, quantify total plaque burden, clearly this technology has an advantage. Big difference in the total amount of calcium that you'd quantify between the methods, and there's less overestimation with the photon counting approach than with the EID approach. And then this technology improves upon what can be done with multi-energy imaging in a way that's very, very specific. And so you can get ultra high resolution images along with multi-energy capabilities together, which is a real strength of the approach. And this allows you to then much more specifically go across the energy range. You can rescue a scan that didn't have a lot of contrast in it. You can tease out what's calcium, you can tease out what's non-calcified plaque, and you can hopefully use it for other things as well, like characterizing mass lesions, thrombus, and things like that, looking around stents and other hardware that's in the heart. And so with that, I'll shift back to the current reality. We don't have access to these systems for all patients. It's even the exceptional patient at Mayo that can get on one of these systems. And although generally speaking, I'd like to say that calcifications with CT are pretty straightforward, they can be difficult even with CT. So this is a patient who has pretty impressive amount of caseous calcification along the lateral annulus right here. And you can see that on the MRI, because of the classic location, I think most of us would conclude that's what that is. But if you do a gated scan, boy, is it easier to appreciate what this is. You can see the density difference of the calcium, the change in the density centrally, and this caseous calcification. And so with that, I'm going to turn to a couple different case examples, highlighting maybe how MR and CT can be used together when it's not necessary. So this is a pretty classic lesion. This lesion's been there a long time. How do I know that? The left atrium is huge. There's a huge soft tissue mass in the left atrium. It's attached to the interatrial septum right here. And so this is pathognomonic for an atrial myxoma. But because we can get a cardiac MR, we can, and so we did. We can characterize it 9 ways to Sunday, but it's still a mass lesion in the left atrium consistent with a myxoma. It's attached along the septum. We can see that there's contrast surrounding it here on the time resolved MRA. You can see that it contacts the mitral annulus, but is separate from the anterior mitral leaflet. You can see that it has some heterogeneous enhancement here on the Dixon fat water images. You can see that it has more uniform enhancement on delayed images, very bright T2 lesion, has some enhancement on perfusion, and it shows delayed enhancement with a classic T2 hyperintensive period. So 15 ways to Sunday, it's still a myxoma. So if you got the CT, I think we'd feel pretty comfortable about what it was. CT can show you if there's calcium that's present or not. And the MR sends it home and confirms there's no thrombus on the surface, if that was a question. So of the two there, I think they're equivalent. You can use either. What about this lesion? So this is a little bit harder to tell. There's a lesion in the apex of the LV. It doesn't have the CT density that would suggest thrombus. It looks like it's, within the myocardium, so that's not usually a good sign. Well, this is a really nice lesion to characterize with MR because you can see exactly where it starts, exactly where it ends, where it is in the myocardium, and see if there's importantly more than one, right? And so in this case, this is integrated into the wall of the apical LV. These are just different tissue characterizations that we have. So this is a mix of proton density and T2. So it's different than myocardium. It's not T1 hyperintense. It has some degree of enhancement. There's a little bit of peripheral LGE associated with it. And on the perfusion image, it's more vascular than the myocardium. So it's a hypervascular lesion integrated in the myocardium here. This doesn't look good. This is some sort of likely metastasis or primary cardiac tumor. And this is an Octria scan, so a somatostatin receptor avid tumor, and this is metastatic carcinoid. So a single lesion in the heart. CT, you can see it. You can say it's a problem. MR, in this case, wins out in terms of characterization. What about this? So this is an RV mass. Show an echo image here. Clearly an RV mass right there. And on the CT, we can see the same thing, but the more you look around this image, you start seeing lesions in the soft tissues of the breasts, along the chest wall, and the fusion, and down the liver, there's even lesions here. So echo, tip of the iceberg, there's a lesion. On CT, we can see that this sure looks like a metastatic process in a patient who has no known malignancy, though this is a problem. And so, of course, you can get an MR. What the MR shows in this case is the entire myocardium is abnormal. It is full, completely full of lesions, LV and RV. If I get this to play, maybe it'll show that. So there's very irregular thickening of both ventricles. This is late enhancement imaging. Again, the same thing. It's completely full of lesions throughout. On the LG, you saw some really nice pictures. Matthias just showed nice black myocardium. This myocardium is very different than that. It's full of these lesions. And this is an axial image showing the same. And this is the T1 pre-contrast image. All these lesions are T1 hyperintense. So this is a melanin-producing metastatic melanoma. So this is a good example of how you can see a little bit of the burden of disease on CT and/or echo, but MR shows it really, really, really well. So this is a tricky one. So this is a patient who presented with chest pain, has pericarditis, and then they have this little area out here along the anterior pericardium that has low signal intensity and looks like a mass of some sort. This is the Dixon fat water images. So signal here on the left from water. There's a little bit of enhancement of the thickened pericardium right there. And on the fat image, you can see this outlined by fat really well. So kind of confusing, some pericarditis. There's this area that we're not sure how to characterize on MR. On CT, we can see that on the pre-contrast images, it's very dense, looks like calcium or at least dystrophic calcification. On the delayed phase image, we see the same pericardial enhancement and this area hasn't changed. And this is a movie showing this a little bit better. This patient has apical access 25 years ago for a mitral procedure. And they put in some pledgeted sutures, and that's just dystrophic calcification in the way they accessed it. On MR alone, it looks very, 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 very confusing. And on CT, it's much more clear what it was. So this is a good example of how you need both, I think, to understand what's happening with a particular patient. So now we're going to get into lesions that are a little bit harder, I think, with MR to do well. So small lesions and lesions that move irregularly aren't really well characterized with MR for a few different reasons. So this is a lesion that's in the apex of the LV. It's moving irregularly. It's like it's trying to be ejected, but it's not able to go anywhere. Question here was whether or not this was thrombus. You see the same thing in the short axis, the lesions here in the apex, kind of coming in and out of the image plane. Things that move this irregular are very hard to characterize with MR. And so this is the tissue characterization or T1 black blood. Can't even see it. LGE, can't even see it. It moves too irregularly for it to be characterized. With CT, though, we see kind of the same approach we saw in the cines, but now we can appreciate the surface of the lesion better and where it attaches. And so this is a really nice way to better understand, based on morphology, shape, and how it moves, what it could be. And so I'll show you the same type of lesion in a different location. So this is at the level of the aortic valve, this little lobulated mass lesion with a thin stalk attaching to the aortic valve leaflets, shown beautifully with TE. So this is a papillary fibroelastoma, just in a weird location. It can occur in the apex of the LV. It's very hard to characterize on MR alone because of its motion. This is a companion case, a recent one, outside referral at Mayo. So there's, movies aren't playing that well, it's a shame. Let me see if I can go back and do it again. There you go. So along that anterior leaflet, I'll just use the pointer here. Oh, got too many remotes here. There we go. Along the anterior leaflet, there's thickening here, and the anterior and posterior papillary muscles insert directly into it. This is a thickened area that was confusing on MR. You can see some thickening here, similar signal intensity to the myocardium, a little bit bright on the dark blood images. And with CT, we can see it similarly, but what's nice about this is it shows, I think, a little bit better how the anterior and posterior papillary muscles insert into the anterior leaflet itself. Let's see if I can get it to play in the long axis images better. There we go. That's a shame. It's not showing as well as it should, unfortunately. I don't know why it's projecting that way. But this is a classic appearance for a mitral arcade. And the confusing part about this with MR is that it was confused as a blood cyst. And it was characterized as such on the images because you couldn't really appreciate how the papillary muscles inserted into the leaflet. So this is a good example of how they're complementary, but I think in this case, the morphology is more important than the characterization sequences. So let's shift gears a little bit away from lesions. This is a patient who had a negative coronary CTA for obstructive disease, acute LV dysfunction, new pericardial effusion, high troponin level. Images here that look like the apex is ballooning out, so like a Takotsubo cardiomyopathy, octopus pot apex. Showing the same thing here in the short axis orientation. So maybe a stress cardiomyopathy. Patient had a recent stressful life event. All the characterization we can do with MR kind of confirms that. So again, looks like a stress cardiomyopathy. And there's one little area here on the LGE images that shows some midwall enhancement, which is a little bit odd for a stress cardiomyopathy alone. This patient also is being treated for metastatic lung adenocarcinoma and was on an immune checkpoint inhibitor. And this is actually immune checkpoint inhibitor myocarditis. And the only way we could make that diagnosis was with the MRI. Until that point, the thought process was it was a stress cardiomyopathy. And just two structural cases to finish on. So this is a pretty classic example of left atrial thrombus. You can see it really, really well here. CT and MR can do it incredibly well. It's in a typical location. There's no question that's what it is. So what would MR have to offer? Well, MRI can help us with risk stratification in patients who haven't had one of these, determine if they're at high risk for developing a thrombus in the atrium or the left atrial appendage. This is a prospective study that I'm involved with among other institutions, Michael Markle at Northwestern. And then because I have to show a flow case, these are two patients who would be considered for a percutaneous tricuspid valve. One of them has much worse regurgitation than the other, although at echo, the degree of regurgitation was graded similarly. And so they have the exact same RV ejection fraction, 46%. Image on the left, much larger RV than the image on the right. Much more regurgitation on the left than the right. This is a nice example of how MRI can complement CT when we're trying to do structural interventions. And with that, I'll finish. Just my schema of how I handle these lesions. I went through some that are more straightforward with, I'd say, either modality, some that are trickier with MR than CT, and I highlighted where I think MR can complement CT in the structural practice as well. I'll just kind of point out that arrhythmia is challenging in both, and I think photon counting CT is going to show its hand a little bit more as it becomes more mature and more widely prevalent. So with that, thanks very much for your attention.
Good. We move on to the next presentation, which is going to be on contrast-free CMR. Can we reduce or replace contrast agents in cardiac MRI? And it's going to be given by Vanessa Ferreira from Oxford University. Fine.
Great. Good morning, everyone. Hello, my name is Vanessa Ferreira. I am the SCMR Vice President. I'm very excited to be part of this joint session between SMRA and SCMR. And I would like to thank the SMRA for this invitation, especially Jeremy, Judith, Claudia, and Renee. In this talk, I would like to share with you how we can reduce or replace contrast agents in cardiac MR. And these are my disclosures. So because we only have 15 minutes, I will not go over all of the non-contrast methods that CMR can offer, but we'll focus on the two most common gadolinium contrast-based CMR methods that we currently use to answer clinical questions. So for myocardial scar assessment, I will go over methods that can potentially produce late GAD-like images. And for the assessment of ischemic heart disease, I will go over stress perfusion methods and alternatives that do not rely on gadolinium contrast agents. So as background, CMR has many techniques that do not require gadolinium contrast agents that we've seen earlier, and yet provide a lot of information about the heart. Even cine images here, so cine images offers high spatial resolution images with accurate definition of cardiac anatomy, structure, and function. And we can get information such as wall thickness and regional wall motion, but they may also have some inherent image contrast within the cardiac tissue that we can exploit. So conventionally, the most powerful capability of CMR is in myocardial tissue characterization using late gadolinium imaging. Late GAD patterns can help us distinguish between ischemic and non-ischemic etiologies of heart disease. For instance, on the right is a typical myocardial infarction, and the late GAD image always involves the subendocardium. And in contrast, on the left is a non-ischemic pathology like myocarditis, and the pattern is very different. You can see mid-wall patterns in the lateral wall and subepicardial lesions rather than endocardial lesions, and they typically do not follow a single coronary anatomy. So parametric mapping, such as T1, T2 mapping, they offer quantitative pixel-by-pixel maps for myocardial tissue characterization. The pre-contrast native T1, T2 maps, they are gadolinium-free methods, and they contain rich information of the myocardium that can detect changes beyond what late GAD can offer. So with these gadolinium-free methods, we can exploit the information contained within them and then use artificial intelligence and machine learning to predict what the corresponding late GAD image might look like. So for example, in Oxford, we began to work with computer scientists and machine learning experts. And essentially, we can generate virtual late gadolinium images using only pre-contrast images like cines and T1 maps. So we call it virtual native enhancement, or VNE, and this is the basic concept. So first, we would acquire pre-contrast images such as cines and native T1 maps, which contain not only the pixel-wise color map itself, but also raw images of different T1 weighting. Then we feed them into the deep learning VNE generator, and the generator would then use multiple streams of neural networks to produce image feature maps. And all the feature maps are input into a further neural network block to fuse the information from these multiple images to produce a final VNE image. Now, we would also have acquired real late GAD images from these patients, so the model was trained using a generative adversarial network to encourage the generator to produce images that look like the real late GAD. And these are examples of conventional late GAD images in the top row and the VNE at the bottom. And so visually, the VNE achieves significantly better image quality with good visual spatial agreement and lesion detection. So in this first study that we published in 2021, we had 4 independent operators score the image quality of the real late GAD and the virtual late GAD, and they were blinded as to which was which. But overall, the VNE achieved significantly better image quality than late GAD. Now, what about the quantification of the lesions? So reassuringly, the VNE also correlated strongly with conventional late GAD in quantifying lesions in hypertrophic cardiomyopathy using various image analysis thresholds for comparisons. Now, we then moved on to develop the technology for other scar imaging and detecting chronic myocardial infarctions, which is a common reason for referral to determine myocardial viability. So in our results, here is a patient who has a chronic MI downstream from the left anterior descending artery. And these are 3 short axis images. And the VNE revealed the infarction on all 3 slices in high agreement with late GAD. And these are the corresponding transmurality plots on the right, where red indicates low viability and green indicates likely viability using the 50% thickness cutoff between the 2 shades of color. And we can see a clear transmural LED infarction on both the VNE and the late GAD. Now, what about infarctions in multiple territories? So here is a patient where VNE revealed 2 infarctions. So one in the septum and one in the inferior wall, confirmed on the late GAD images. And again, we see a high agreement between the two methods on the transmurality plots on the right. So on quantitative analysis in the testing dataset, the VNE correlated strongly with late GAD in infarct size as a volume of the left ventricle, and in quantifying the average transmurality of the infarcted segments for each patient. So as a proof of principle validation, we also tested the VNE in a pig model of chronic infarction with CMR and histopathology data from our collaborator Rohan Damakumar when he was in Cedars-Sinai and UCLA. And VNE revealed a clear LED infarction in these two test cases in high agreement with the ex vivo slices and histologic staining. So we are very excited about the technology, and this is a great opportunity. We're working on validating it for other common pathologies and clinical applications. So moving on to using CMR to assess for ischemic heart disease, we will first review the current stress perfusion methods, and then some gadolinium-free alternatives such as dobutamine stress CMR, oxygen-sensitive CMR, and of course, some of the latest development in coronary MRA. So standard CMR perfusion imaging offers high spatial resolution and dynamic images of myocardial perfusion at rest and during stress. Now, this requires injection of gadolinium contrast agents to visualize the inducible perfusion defects in different coronary territories. So here is a patient with a severe blockage in the left anterior descending artery, as seen in the angiogram in the bottom left. And on this adenosine stress CMR, we can see clear inducible perfusion defects in the downstream territory in the anterior wall and the septum. So moving into the era of quantitative mapping, these are novel stress perfusion blood flow maps and do require gadolinium contrast agents. So on the left here is a healthy volunteer showing significant augmentation of myocardial blood flow at peak vasodilatory stress compared to rest. We can see an over 3-fold increase in myocardial blood flow in this example. And on the right is a patient with triple coronary disease and showing very impaired myocardial blood flow in all 3 coronary territories. But importantly, quantitative perfusion maps can allow us to visualize and diagnose microvascular dysfunction. So this is a patient with typical angina, but normal coronary arteries. And we can see that there is a characteristic circumferential ring of purple or subendocardial myocardial hypoperfusion during vasodilatory stress. And here's another example of microvascular dysfunction in apical hokum. Again, we see that signature circumferential subendocardial hypoperfusion of myocardial blood flow during stress. Now, I want to show you dobutamine stress CMR, although this is less commonly available. So this is a patient with chest pain, and at baseline, the cardiac function is pretty normal overall. No regional wall motion abnormalities, that we can, discern. But when we increase the dobutamine infusion to 20 mics per kilogram per minute, you begin to see an inducible wall motion abnormality in the inferior wall and the inferior septum. And this doesn't require contrast agents, and you can diagnose ischemic heart disease this way. This is very similar to dobutamine stress echocardiogram. Now, if you do want to include perfusion imaging, you will need to inject gadolinium contrast, and these are the stress perfusion images showing a clear inducible perfusion defect in the inferior territory. And the late GAD images show a very small subendocardial infarction in the inferior wall. This is less than 25% thickness. Okay, so moving on to oxygen-sensitive CMR. Oxygen-sensitive imaging is also known as blood oxygen level dependent or BOLD imaging. And you can use this to assess for ischemic heart disease, typically using T2 or T2 star-based images and some kind of stress. So here at the bottom left is a healthy volunteer with corresponding rest and stress T2-based images. And on top is a patient with coronary disease, and we can use BOLD imaging to detect regional abnormalities in the inferior wall, showing a lack of signal change between rest and stress. And briefly, this is how BOLD works. So in a normal individual without obstructive coronary artery disease, at rest, not all the capillaries are vasodilated. But if we give this person vasodilatory stress, such as dipyridamole or adenosine, this will recruit and vasodilate additional capillaries. Now, in a person with a severe blockage in a coronary artery at rest, there is post-stenotic capillary recruitment, and they are vasodilated at rest already. And this increases the relatively intracapillary blood volume, which means we have more deoxyhemoglobin. Now, deoxyhemoglobin is paramagnetic and will cause more dephasing of T2 star at rest. And further, if you give this person vasodilatory stress, the coronary capillaries here are unable to further vasodilate. So you will have decreased signals in bold imaging in this territory. So you can use bold imaging to investigate obstructive coronary disease like we've seen earlier, but there's also interest in using bold in patients without obstructive coronary disease to investigate for evidence of microvascular dysfunction. And this study uses bold to study patients with different variants of hypertrophic cardiomyopathy and showed that despite having normal stress myocardial blood flow in some patients, they can show blunted changes in the oxygen-sensitive signals already, including in pre-hypertrophic variant gene carriers. So bold may be sensitive in picking up some early changes and, again, don't require gadolinium contrast agents. So finally, coronary MRI. And Renee and Claudia's teams have done some really interesting and impressive work on free breathing, 3D whole heart MRI looking at coronary MRA compared to coronary CT. So this is a contrast-free scan, and they're able to achieve a sub-millimeter voxel resolution. And together with using beta blockers to slow the heart rate and nitrates to vasodilate the coronary arteries, this good image quality, you can rule out significant obstructive coronary disease with 100% negative predictive value. And here are some wonderful examples of high-resolution coronary MRA, the ones in red, compared to coronary CT in all three coronary territories, so RCA, LAD, and circumflex. And they have also developed methods that can not only visualize the coronary lumen, but also perform thrombus and myocardial edema imaging. And this is a patient with an acute MI, and this shows a blockage in the lumen of the LAD artery with acute thrombus and downstream acute edema in the anterior wall. And these data sets here show that it is possible to perform plaque analysis on coronary MRA compared to coronary CT. And again, these do not require gadolinium contrast agents. So in summary, CMR is multiparametric. There are many contrast agent-free methods for assessing cardiac structure, function, tissue characterization in coronary arteries. And common gadolinium-based images for clinical application include late GAD imaging for assessing myocardial scar and viability, and stress perfusion imaging for assessment of ischemic heart disease and microvascular dysfunction. There are some alternative GAD-free methods that are still in active development, and these include the T1, T2, T1 row mapping. We showed you virtual native enhancement. This is in active development. It's not available for routine clinical use yet. There's butamine stress CMR, oxygen-sensitive or bold imaging, and coronary MRA. And in the near future, it may be possible to achieve GAD-free CMR for basic protocols and the common indications. So with that, I will bring this talk to a close, and thank you. Just a very quick note that SCMR is going to hold its annual scientific okay, there you go. Session in Rio, in Brazil, for the very first time, outside of North America and Europe. So, save the date and consider coming. Thank you very much.
Okay, thanks very much, Vanessa. Next up, we have Ruud van Heeswijk, who's going to tell us about the role of fluorine-19 molecular MRI in imaging cardiovascular inflammation.
Thank you very much. Hello, everyone. So I thought I had to add like a slide here with some Monty Python reference, and now for something completely different, because I'm going to talk about an X nucleus. But after the amazing talks you'd had already yesterday and today about CT, about attometer scale imaging and so on, I think I'm not even going to be that strange with my fluorine-19 MRI. So let's see which buttons do I press. Yeah, here we go. So the main question that I'd like to ask is one of these last few missing puzzle pieces that we have in cardiac MR or cardiovascular MR in general is, can we image inflammation, right? We can do something like T2 to highlight where there might be inflammation, but unambiguously certainly not, and we cannot really quantify it, let alone monitor it. So I'm going to try to convince you that yes, we can with fluoride 19 MRI one of these days. So let's start at the beginning. So here's a callback to your middle school. Normally we do imaging, of course, of proton, but we can image many other nuclei as well. And today I'm going to talk about the fluoride nucleus. It has some big advantages compared to other X nuclei. It is very highly sensitive. Most other nuclei are not sensitive at all compared to hydrogen per atom and so on. And it has almost 100% natural abundance. So if you find some fluoride, it's going to be the right type. And a cool occurrence is that there is no real occurrence of fluoride in the body. There's some in your teeth, but that you can't see in MR. So if you make a normal fluoride image of the body, you won't see any signal. So you need to inject something. And by the way, fluoride has been around for MRI since ages. Here you see some images from Bottomley in Holland from the end of the 70s already, one of the first things that were looked at. So what do we look at with fluorine MRI? Well, these are perfluorocarbons. These are chemically inert, very stable compounds. The fluorine carbon bond is one of the most stable, or the most stable bond in nature, and our body cannot break it down. So if you inject one of these compounds there where all hydrogen's been taken away and been replaced by fluorine, you can't break it down. It just sits there, takes up volume. But since it's lipophobic and hydrophobic both, we tend to put it in some nanoparticles. And here you see some structures. And by the way, these days, I'd also like to point out, don't confuse it with this PFAS, of which is a large pollution problem at the moment, because these compounds, they're partially fluorinated and they are not. So where might you have seen fluorine in the past or perfluorocarbons in the past? I don't know if you remember this movie from the end of the 80s, I think, by James Cameron, where the main character goes very deep in the sea and then he breathes this liquid. And that's not science fiction. That has been done mostly by some American Navy SEALs and other people like that, I think. But mainly perfluorocarbons, they have a higher oxygen carrying capacity than even air. So you can breathe this liquid because it can take up so much oxygen. That was what it was initially used for, liquid ventilation. Then people found out if you take these nanoparticles, they also keep transporting oxygen very well. And these particles are very small. They're 45 times smaller than red blood cells, for example. And it has been used already in phase 1 and 2 trials and even phase 3 trials as a blood volume expander. So people have been injected with up to ½ liter of this stuff to replace their blood. So relatively safe as these things go. Of course, cyclists also found out about this, and then some cyclists tried to play with it as well to enhance their performance, but it didn't work out that well. There were a few of them were hospitalized because they, of course, take too high dosages and so on. But so the stuff's been around for a while. But basically, it was Uli Vleugel from Düsseldorf in 2009 who kind of reignited this whole field. He made these nanoparticle formulations, and as you can see in the bottom left, all you had to do here in the stroke and an infarct model in the same paper in Circ is make a proton image, then do a fluorine image and overlay the two of them on top of one another, and then you would have this nice inflammation map. And that's essentially what's being done a lot. So you have 3 types of fluorine MRI roughly these days. So you have the ex vivo cell labeling. So here you take some cells from the blood or from the body in a petri dish, label them with fluorine, then you re-inject them and you see where they go. You can do in vivo labeling, so you just inject perfluorocarbon and you hope to see where it goes. And finally, you can add some antigens and other things to do some target-specific imaging. But today, we're going to focus on this middle type. So here's an image in the infarct, in the bottom and so on. You just inject perfluorocarbon systemically, you wait a while, and you see where it goes. This works roughly like this. So if you look here, you have the perfluorocarbon, you inject it in an animal, it gets taken up by immune cells, and then these immune cells, they will go to a site of inflammation, so typically macrophages, dendritic cells, etc. And there's your inflammation. And remember, you only see the fluorine signal, so the signal that you see is linearly proportional to the quantity of fluorine that you have. And then comes also the last advantage compared to, for example, iron oxide. So one, you have this linear relationship between the amount and the amount of perfluorocarbon present and the signal. But two, you also have you can monitor this stuff over time, right? Iron oxide doesn't really leave the tissue. If you inject it, like you see here, for example, in this mouse brown fat deposit, they injected an irritant, then injected a perfluorocarbon. And the really cool thing is that the fluorine signal, the immune cell concentration, and the irritant, they all follow the same time course, as you can see. So you can really monitor inflammation over time with this. So overall, fluorine MRI, no background signal, easy quantification, easy translation because of safe molecules, clearance from tissue with this so unique monitoring over time. But you do need special hardware. You need this broadband amplifier and special RF coils and so on. And you have relatively low sensitivity, but high specificity, so that should compensate. So what can we do in cardiovascular disease? We started exploring that like 15 years ago or so ourselves. And the main take-home message from this immunofluorescent histology slice is that if you look at the perfluorocarbon, which is in green in the second one, let's see if I can highlight this. No, I cannot, I think. Perfluorocarbon in green and the macrophages in red. The two on the extreme right, they completely overlap. So yes, all the perfluorocarbons are in the immune cells. This was in a mouse model of myocarditis. Let's see. Why does it not want to pass? And so here you see an image of a mouse myocarditis in vivo. You can even see that the inflammation, the right ventricular wall, tiny in a mouse, of course, stands out, which we also confirmed ex vivo. And then when we did the histology, you can see, right, the inflammation, the infiltration of the immune cells is even in a thin part only of the right ventricular wall, but we still saw that signal in vivo. And this very nicely correlates with the disease degree, even before any functional changes. So great, we can image active inflammation, acute inflammation, but also chronic inflammation, like here in the mouse model of atherosclerosis. We could very nicely highlight the plaques, as you can see here in this 3D render also. Of course, inflammation is one of the key hallmarks of atherosclerotic plaque, of vulnerable plaque, and even in this mouse model, tiny aorta, tiny carotid artery, we could highlight carbons and thus the inflammation, and then confirm it with histology. So after having shown you that yes, we can do this in mouse models and so on, the next question becomes, how can we get this now into the clinic? So the first person to do fluorine MRI in the clinic was Eric Ahrens. He labeled some cells ex vivo, so he took some cells in a petri dish, or in vitro, I should say, and injected these few cells in some stage 4 colorectal cancer patients and just detected the cells. So this was a very limited initial trial. It was not a systemic injection, but it showed already that even these few labeled cells, you can quite clearly, nicely detect them. But we were interested, of course, in cardiovascular diseases. And for example, here, Lifleugel and his group, they took a pig model of infarction and then injected the perfluorocarbon after the infarction and see where it went. And what you can see here nicely already in this gross pathology and in this fluorine image, you can really see that they occupy the same area. But even more interesting, if you see this histology then afterwards, you see the late gadolinium enhancement on the top left. And you see this the histological match on the top right, and you see the non-overlap of the fluorine signal in the middle with the histology with the late gadolinium enhancement signal on the top. So you really can show inflammation and not scar and differentiate the two with one another. So you really can nicely look at salvageable area and this kind of thing. They then also took this one step further, and they did in vivo imaging of a pig model of infarct with some 3D BSFP imaging, and just average for 20 minutes, right? The easiest way of motion correction is averaging. So if you just acquire the same image for 20 minutes, you get a very nice in vivo image as well. Here in this pig model, you can see the operational wound and the infarction itself. And then very interestingly also, they noticed that in the pigs that didn't have any signal, where there was very little SNR, they could see some positive remodeling, while the high inflammation or the high perfluorocarbon signal animals, they had the more adverse remodeling. So all very promising and so on. So why not in humans and so on? We worked on this kind of thing ourselves as well. So we looked at how can we make these things more sensitive. So then we did some compressed sensing together with averaging and so on. And as you can see in this mouse model also, we can very nicely now get much more signal, become even more sensitive with modern reconstruction techniques. So, and here we also do more averaging. So we increase the robustness of the whole thing as well. So that brings us now, after a bunch of technical improvements and having seen feasibility in animals, what can we do? What do we need if you want to do fluorine MRI? Well, we need a broadband amplifier. Yeah, many academic centers have those. We need the fluorine RF coil. We have those as well. Pill sequencers, with most vendors, they're fairly straightforward to get for nuclei. But then comes the tracer, right? This is the pharmacological and regulatory problem of this thing. How do we get a tracer? Because afterwards, after you've got these things, there are a bunch of positive and negative aspects from translating from animal to human setting. But if you go from all this mouse stuff, as we saw already in the pigs, we have much larger voxels and so on. So it should be quite straightforward to get a decent signal in. So I was lucky enough to find this company in Glasgow, in Scotland, and they were interested in marketing this perfluorocarbon here for stroke reduction, or for targeting the penumbra of stroke area. They essentially wanted to see if we could use the oxygenation capacity of the perfluorocarbon to reduce stroke size, as you can see in this animal model on the bottom left. And so they were not even aware of the fluorine 19 MRI possibilities and so on. And they have this FDA stage 1 and stage 2 approved compound and so on. So I could maybe skip the pharma side of things and go for this. Then I tried this compound for MRI. And as you can see here in this NMR spectrum, you have one massive peak there, the CF3 thing, which is more than 100 ppm away from this forest of other resonances. So you can just do regular normal imaging with this compound. Then we also did a bit of kinetics studies to see what the clearance was. And as you can see, in both the spleen and the liver, it clears in about 2 to 10 days or so, depending on the animals. Meaning that it doesn't stick around like some of the other perfluorocarbons for like months at a time and so on. So clearance also pretty nice. So we then also bought an RF coil and went to see if you can get some signals from the neck, and if you could do some quantitative imaging of the fluorine to see if we could do really what we wanted to quantify the inflammation. So we got this nice little phantom set up, and there we also saw that yes, we can quantify at the real clinical setting, we can quantify our fluorine signal. So I then got a grant from the Swiss National Science Foundation to do fluorine imaging in carotid plaques, essentially, see if we can quantify inflammation together with some parametric mapping and so on. And that's where we are now. I had hoped to by now roughly have my first patient and so on, but the delivery of the compound is a bit delayed. So this is where I'm at the moment. I have paid the material. I have signed the contracts with the manufacturer. I have the approval from both the IRB and the regulatory affairs, so the Swiss FDA, let's call it that way. And I should be able to start somewhere at the end of this year with our first patients in the carotid. So that's where we're at the moment. So the take-home messages here overall, I hope I could convince you that fluorine MRI is a background-free modality that allows for the quantitative monitoring of inflammation. The sensitivity is not really a problem. It has been improved quite strongly already, but acute inflammation especially should be easy to image and quantify with all these new imaging techniques, all the modern denoising and compressed sensing reconstructions and so on. And translation to the clinic is challenging, but we're almost there, so it should be quite achievable with the right tools and people. And several trials, including mine, have recently started, so are funded. So yeah, looking forward to that as well. Thank you for your attention.
Thanks a lot, Ruud. We move on to the last presentation, which is an industry talk. The title is Recent Innovations in MRI, a Regional Perspective on Global Progress. And the presentation is given by Daniel Giese from Siemens Healthineers.
Yes, hello everyone. Thanks for having me. As you can see, I'm not the person that was supposed to give the talk here due to an emergency. He couldn't come today, so my first disclaimer is please bear with me with this in the next few minutes, where I'll present some slides that I don't know as well as I would know slides if I were to give a presentation earlier. Okay, let's start with this slide here. I enjoyed the little discussion we had yesterday about how we all want the same goal of bringing our research to a broader audience, a broader patient cohort, and I think we all work on very similar areas. Maybe the workflow topic is not the main topic of the researchers, but I think we need to focus on there very heavily as well to be able to bring our developments to more patients. And this obviously is a fast, a free breathing, planning, an easy planning, potentially with less user interaction. We know that cardiac MRI is not an easy isn't an easy scan to do, and this then includes also the sequence development, the acquisition, but also the reconstruction. And in the next few slides, I want to show you a few examples of prototypes and products that we have in order to simplify MRA on our systems. So the MyExam Angio Assist, as you might know, really helps you to plan peripheral angio scans, contrast enhanced. You all know that that's quite a challenge to be able to time it and to move the table, to be on time with the bolus, etc. So this assist workflow here really helps you to cover the entire abdomen to feet area, and then to acquire the peripheral angio images with quite an easy workflow. We also have this for cardiac imaging. Marta might pronounce this a bit different, but this is the Automate Cardiac Assist that is currently also in the newest software versions of our scanners. As you know, that a cardiac scan in general and also an angio scan is quite complicated to plan. So we've integrated auto positioning without user interaction, placing the main imaging slab, the saturation bands if required, the navigator, and also the shimming volume. Also to plan some LGE scans, for instance, or also to plan some angio coronary scans, we need to determine the resting phase of the heart and of the regions of interest. This is performed using an automatic resting phase detection. And for LGE scans, we need to know the myocardium signal, and this is performed using a TI Scout with an automatic selection of the inversion time. All of this is packaged into the so-called Automate Cardiac workflow, and this is available and pluggable into all of your sequence you want to use for a full cardiac exam. We heard a lot about native MRA in the last talks and yesterday. We have I would say a very classical approach here, a Cartesian approach which is highly accelerated using compressed sensing, and which allows a free breathing, ECG triggered, high contrast and water fat separated MRA scan. It's fast and it's efficient. You can combine it with the just proposed automate, so you have an image like this within a few minutes without needing to plan this image. So you have a very effective workflow here. Sorry. Yeah, and our friends here at Semmelweis, they took the challenge and took the sequence and planned it in 2 stages to potentially use this native MRA to plan TAVI procedures. We all know that this is performed typically using CT, but for patients contraindicated for CT or they shown, and their first examples show that potentially they could also use this native MRA for the planning and maybe also even to see the coronaries, which is also very important. Obviously, for this native MRA scan, the calcification is still a challenge to detect. And here you can see a fly through this whole thorax, including descending aorta scan, which is then needed for the intervention. We also work and have developed deep learning reconstruction methods. As you know, potentially these methods take quite a long time to reconstruct, but we've optimized this to be able to run directly on the scanner. So you see the images within a few seconds. This is not longer than a compressed sensing reconstruction, but offers the advantage of automatically found regularization parameters, and an initial study by us with some clinical colleagues showed that comparably it is to compressed sensing and also has some advantages regarding artifact suppression. So this is a case-based to image reconstruction, so it also includes data consistency. We've seen different flavors of the work and of the sequence that is now also included in WIP packages, but also part of it in the product of this predictable scan time and geography developed by René and Claudia and colleagues, where they have pushed the boundaries now even further to allow some different contrasts in a single scan, and showing some bright blood and some black blood images automatically, obviously co-registered because it's the same scan. And this so-called boost sequence has been applied at various centers around the world. Here's an example of some cases from here locally at Semmelweis, but also KCL, where they can image and clearly see the thrombi within the atrium using this sequence, which has a predictable scan time, which is very, very important, especially for cardiac patients, as you can imagine. Another application, we're focusing a lot on cardiac imaging, but also yesterday we saw a few examples of carotid imaging. So applying this technique, which then maybe is a bit simpler because we don't need to care so much about ECG variations or breathing artifacts to the carotid arteries, and giving you a vessel wall imaging approach, but on the other hand also a very bright blood imaging, so you can in one scan visualize the lumen but also the vessel wall. And also here at Semmelweis they have pioneered this and are looking into this in more details. And And in general, with patients that have contraindications for contrast in the MRI, this technique is also very helpful. And here's an example of a direct comparison with a CT. A bit more technical approach or solution that we can that we offer is the so-called FIRE framework. I'm very sure all of you have already seen this. It's a framework that allows you to put on the scanner directly your reconstruction or post-processing networks or machine learning or classical algorithms. So you can extract the data at any point of the ICE pipeline, so to say, and then you can re-inject your post-process data back into this pipeline and then see all the results on the scanner, obviously, then also connected to the PACS, etc. So this is really a tool that is heavily used by our basic research partners. And here are just two examples. We didn't see too much of 4D flow yesterday, but we all know that 4D flow is a very heavy post-processing, is very difficult to post-process and takes a very long time. So we decided to at least show a snapshot or some basic quality metrics and also quantitative flow directly on the scanner once the 4D flow acquisition has finished. And this is a feature, I think, that is very important and can help to decide if the data quality is good enough. It is not a feature that will be used instead of a thorough retrospective post-processing of the 4D flow data, but it gives you an impression of how your data quality is after a 4D flow scan. As you might know, we also have this C2P exchange platform that I will encourage you to have a look at. These are, there is the possibility to exchange some algorithms from partner to partner. This is used quite heavily, and I would, anyone who doesn't know this, I would really recommend to have a look at this website here. And here is one application, one example of Matthias's group in Lausanne, who also used the FIRE framework to do something very similar, as I just said, for the 4D flow, to give the clinicians directly a feedback on how the image of this very large data set that they acquire using their free running, to give them a direct feedback of how the image quality looks, and then but also takes the data offline, then does the heavy reconstruction, and then puts it back on. So I think this is a nice example of how FIRE can be used to help with the confidence of some very heavy scans and a lot of data that is acquired. A few slides about the low field solutions we have. You've seen the nice talk from Matthias this morning. Here are just another few examples of our partners that have the system since a few years now, and really showing that the advantages of having a low system, which is a very homogeneous B0 field, can really be used to acquire beautiful 3D images, like seen on the right-hand side, native MRAs, but also contrast-enhanced MRAs, like seen on the left-hand side. So I would also encourage you to come to the SCMR next year, because there will be a continuation of this midfield cardiac applications. So with this said, coming to my last slide, I want to thank you again for bearing with me here, and I hope I could show you a few developments from our side. And if you have questions, and also in general, please have a look at this magneton flash that we have here, but also on the booth at the back. And if you have questions, please come to me. Thanks.
Great, thank you very much. I'd like to invite all the speakers to come down here. We're all still here, and we've got about 10 minutes for discussion. We're gonna try and stay on time. Think about some questions. If you have questions now, I believe there may be microphones going around, or you can stand up and ask the question. And if we don't get to all the questions, everyone will be out in the coffee break.
Yeah. 4 seats available.
No.
Thank you for the interesting talks. I have a question to Brute Heswig. We had gardofluorine as a contrast medium years ago, but it never came to the market. Why? I think it was a problem of toxicity, wasn't it? Do you know something about this?
Oh, that's probably before my time, but the gadolinium, yeah, I'm not aware. I guess that's for the gadolinium part. So I guess it was for LGE and whatnot. So maybe that was probably not a perfluorocarbon. So if there are other functional groups still, then I guess you indeed would have other toxicity problems.
I think René Bodnar was a co-author of a paper with gardofluorine, but of course it's years ago.
Yeah, you talked to me about this yesterday. I forgot about it. So, but I have a question. So what is the maximum amount that you can inject in a patient now, because you're planning this clinical trial? Because I think sensitivity is probably always the issue.
Yes, indeed. No, the dose that we have the authorization for is 3 milliliters per kilogram, up to a nominal maximum of 100 kilograms. So it's quite a large amount. So 300 ml volume in total is allowed indeed.
This is question is about for the rod about the C19, and this is very interesting approaches. I just wonder if I have a chance to observe longitudinal change for the macrophages in vivo. You know, like myocardial infarction and go to chronic myocardial infarction from M1 to M2 macrophages.
Yeah, there are some mouse model studies indeed about this, the whole differentiation of M1 versus M2. But of course, what the type of study that I'm doing is really systemic injection. So there, in theory, everything will light up. So there you cannot differentiate between the two. There have been some studies where they take specific markers on the outside of the particle so that they target specific M1 or M2 populations. But that's kind of a separate thing, and then you would need to get a separate authorization for that compound, et cetera, et cetera. So there might be a preferential uptake in humans. Of course, there have only been these animal studies so far, so we always assume that the physiology between mice and humans is kind of the same, but it doesn't always work out that way. But it might naturally do that it is preferentially taken up by M1 or M2. That's an analysis that we'll need to do. But for the moment, it's systemic and it gets taken up by all phagocytotic cells. So I would say, no, you can't really differentiate the two. But yeah, we would have to see.
Thank you.
I have a question about the dual contrast imaging, i.e. bright blood and dark blood imaging. And thrombus imaging. So my question is, what is the ponderation of the dark blood? Is it T1 or is it T2? And the second question is there any use to add gadolinium, if it's T1 or 18, in order to increase the signal-to-noise ratio?
maybe you, Renee, you're the expert in this as well, right? This is your, the T1, the contrast really helps for the blood pool imaging. So for the bright blood, definitely. I would say for the black blood, you need to adjust the TI then that you want to, if you want black blood with contrast, I suppose, right?
So we don't have experience with contrast with that sequence because it was developed as a black blood sequence. So maybe it's possible, but it was not the goal. If you give contrast, then the first heartbeat will be bright. So the angiogram is probably nice. The black blood may fail. So as Daniel said, you probably have to adjust the TI. And the scan time is about 10 minutes, depending on the resolution, I would say. Yeah.
Yeah, very nice talks, by the way. And I have a question for Matthias Stuber about the free breathing, free running acquisitions, where you extract your cardiac motion and respiratory motion information from the image data. And I'm just wondering, that sort of implies that there's a steady pattern of breathing and heart beating for the entire duration of the acquisition. And I'm wondering why nobody does the combination of both the ECG, respiratory bellows together with the information within the pulse sequence as kind of like a double check for more precise motion monitoring.
You're absolutely correct. Of course, that would be an interesting solution to be pursued, to integrate this information, to be smarter about it, maybe to even increase or improve the fidelity of these motion assessments. But the original goal was to become really agnostic of EKG and all these, traditional means of suppressing or resolving motion. So as you see, we can also do this on a system without EKG device. It works beautifully, and I think so this is, of course, very interesting. On the other hand, I'm not sure or not certain that we can get rid of the EKG altogether, because if we have pre-pulses, for instance, then we ought to know where in the cardiac cycle we are. And you're absolutely right. The combination of this would probably make the binning even more powerful. I agree.
Got a question for Jeremy. So photon counting CT, I know we're going away from MR, but the images are really spectacular. I'm sure you'll agree, particularly for the coronaries. What about these elusive areas like scar with photon counting CT? I don't know if you've any experience. We tried that way back in the day, you may remember. And even, can you use photon counting to characterize thrombus at this point in the heart?
So you can. We're still trying to figure out how to optimize those protocols, in our practice. So our system has 4 photon counting scanners, soon to be 4 photon counting scanners. The problem is everybody wants to use them for everything all the time, right? So I think the sweet spot for us in our practice is going to be the combination of wall motion assessment with SCAR for those patients that have limited image quality with MRI. We can't get them an MRI. So they have an arrhythmia. The EP docs are trying to localize where they need to do their mapping to see if they can ablate a focus that's inducing either tachycardia or maybe even fibrillation. The problem is that the wall's thin there, and with the artifact from the existing leads, it's still a problem. And so I think we're still trying to figure out the right way to do this, but the multi-energy capability is far superior, and you can really bring out with the low KEV reconstructions, the iodine in the wall. And so it does look like this will be a way to do this well. The problem is these patients have arrhythmias, right? And so you have to optimize the acquisition to make sure your image quality is sufficient to see that. So the contrast resolution is there finally, but we're still trying to see exactly how to optimize the protocol. And then for thrombus characterization, the same. We do multiple phases of the acquisition, and you can see with great confidence the morphology and the location. We're still trying to understand if there's something about the way we can characterize it that gives us complete confidence that's what it is, even when it looks odd or is in a weird location or has calcification. So it's coming. We just need a little more experience, I think, to feel as comfortable with them as we do with MRI.
Dana?
I have a question for Vanessa Ferreira. I thought the stress bold imaging was kind of exciting, and my question is something.
I know that you also worked on T1 mapping with stress. And I'm also wondering, so why T2 star? Why not T1? Why not T2?
Like, why not a stress T2? Is
Stress
that
T2?
stress T2?
Or what about the stress T1 methods that I know you've worked on?
So we haven't really tried the stress T2. I know there are some papers out there. I wonder if the signal is just, too little, because I don't know that, Renee or, any one of you have tried, stress T2 mapping, but even T1 mapping, what we had to deal with is the heart rate sensitivity, correct? Because if you stress somebody and you give them vasodilatory stress, the heart rate is going to go up. So if you have a T1 mapping method that is heart rate dependent or have heart rate sensitivity, you really significantly underestimate the T1 response when they are tachycardic. Our method in Oxford, we have, significantly diminished, heart rate sensitivity. And so even then we achieve like a 6%, increase in healthy people. So it's 6, right? The signal is quite, it's modest, and you really need a tight normal range, in order to be able to kind of detect that kind of difference. And I don't know whether we can achieve the same with stress T2. I don't know. Like, you do want to comment, on that?
I saw that your oxygenation mapping is probably the T2. I mean, at least that's a T2 weighted scan. That's my understanding. So probably maybe
using bold imaging, using bold imaging, maybe, we can, do that. And there's, because Betty Rahman in Oxford, she's, tried to optimize, that sequence. So, that is, one way. I thought the question was, why didn't we do stress T2 mapping? So that's what I was answering, but I didn't realize you were asking about the bold. I don't know whether I answered your question.
No, that was great. Thank you.
Okay.
I have one more question for you, Vanessa. I really like this virtual native enhancement. It looks quite amazing. So my question is, what is the respective, let's say, influence of the CINE and the T1 mapping? Let's say if you left out the CINE, would it still work? And when does it fail?
Yeah, no, a really good question. So, it really works best in a combination of the CINE and the T1 map, because the fail cases, I'm very interested in fail cases. And usually it's a very small subendocardial infarction, that isn't causing a wall motion abnormality, right? If you just played the CINE and you only had like, I don't know, a 10% thickness or a 25% thickness, the wall motion looks fine. And it's right near the blood pool, maybe in an apical slice or the lateral wall. That's when it kind of goes a little bit, wonky, and you need more data sets to train the neural networks to be able to identify that kind of small subendocardial scars in the apical and lateral wall. So that needs a bit more further development. Yeah.
One final question, Dr. Prince.
Yeah, so we published 2 papers. So for the MI one, there was like 800, patients, but each patient has, many slices as well. So we had like, in the order of 2,000-3,000 data sets, because each slice would have a different kind of morphology. So the time scale, to clinical development. So we are just about to put out a paper of multi-center testing, because, with AI and machine learning is very sensitive to, whether using just one single center and that hardware, that environment, whether it translates to other centers as well. So for clinical application, you really want some validation data in multi-center, testing. So we need to do that bit of work first, to see how it fares. It looks promising. And again, we are concentrating on the failed cases. I just saw a comment, on LinkedIn a few days ago And one of the experts saying that we really should kind of focus on why AI and machine learning fails, not when it's so much better, it's so much faster, and yeah, we know that, but we're interested in when it doesn't work and solve those problems, and so we're focusing on that at the moment. Yeah.
Okay, thank you very much to all the speakers. This was really great. If you have more questions, hang out during the break here. I'm sure they'll stick around. Please be back here by 10:50 so we can stay on time. Thank you.